All right. Hello, everyone. We are going to go ahead and get started right at noon because just like last week, we have a lot to cover in a short period of time. If you didn't join us last week, that's okay. We are going over The Menopause Brain by Dr. Lisa Mosconi. And in our first workshop, I go through and I introduce her and let you know her background. So if you're interested in that information, I highly recommend you head over to our website or our YouTube page and watch the recording of that one. Today, we are here to talk about hormone and non-hormonal replacement. So just a reminder, our first workshop, we covered basically the basics of the brain hormone connection and how those work and just the overall basis of what menopause is, what stage of life it is, how it affects our hormones. And so that's what we covered there. So I will not be recovering anything that we discussed last week. Today, we'll talk about hormonal and non-hormonal therapy. And then tomorrow, or not tomorrow, but next Thursday, we're going to talk about lifestyle and integrative health. So this is where we'll talk more about nutrition and the foods that we can eat that can specifically affect those same hormones that are being affected during menopause. So we want to make sure that we are being very clear about what the process will be because I want to be able to answer all of your questions, but that is just not going to be possible because there's so many things to cover. So we've split it up into 3 different sections. However, if you do have questions anytime during this presentation, and especially if it has to do with what I'm talking about, please feel free to throw those questions in the chat. I may not get to them right away because as I see them come in, if there's something I know that gets answered later on, I will probably just ignore them, or I will answer them at the end of class. So let's go ahead and get started. So the first thing I want to start off talking about anytime we talk about hormone replacement therapy is the history of hormone replacement therapy. So in the past, menopause meant a lot of fear and uncertainty for those of us unlucky enough to experience it, which, fun fact, is 100% of all women. So in the past, specifically before 1942, the way that you dealt with menopause was opium prescriptions, exorcism, and even institutionalization. And so menopause treatments were quite literally a house of horror. Eventually, scientists learned of estrogen and some of its functions. And so by 1942, the first hormone replacement drug was approved by the newly formed Food and Drug Administration. From here, hormone replacement therapy goes on many twists and turns, and it falls from grace a couple times and then it rises. So the first fall of grace for HRT, which is hormone replacement therapy, was in 1970s. This was when researchers found that Premarin, which was the primary form of HRT at the time, increased the risk of endometrial cancer. However, they also found that by reducing the amount of estrogen and adding progestin, the synthetic form of progesterone, that protected the uterus, and so Prempo was released. By 1992, hormone replacement therapy was the most prescribed pharmaceutical on the market. So it may have fallen from grace in the 1970s, but it quickly rose again. And it was marketed as the way to be a more vibrant and sexy postmenopausal life. Also, the anecdotal evidence pointed towards protective factors such as heart disease and osteoporosis on top of the reduction of hot flashes. And so while breast cancer was a risk, especially in the 90s, many women were advised to not worry about it. And so when menopause hit, this was just what you did. You went on hormone replacement therapy. And then it had another fall from grace. And this one is probably the one we're the most familiar with. So in 2002, a literal bombshell was dropped. The federally financed initiative called the Women's Health Initiative, which was the largest scale women's research that had ever existed. And it pulled the plug on this initiative 3 years early. This research enrolled 160,000 postmenopausal women. This is really important. They were postmenopausal women. And they were enrolled in a multi-year comparison study looking at estrogen hormone replacement therapy and comparing it to estrogen with progesterone hormone replacement therapy. In 2002, they ended up pulling the plug early because they said that the findings were too dangerous to ethically proceed. They found that women on hormone replacement therapy were having more heart issues instead of less. There were risks of stroke and blood clots and breast cancer, and even dementia was increasing instead of decreasing. And this spurred 20 years of huge debate that is still very much ongoing. And because of this debate, there has been a cost in the education of our doctors and OBGYNs at large, because there has just been so many unknowns. And so we're going to break down the findings of the Women's Health Initiatives and the findings of the studies done after. The reason why I wanted to start with this is because once we can understand the risks when it comes to hormone replacement therapy, I want to give you the most education I can so that you can decide what's going to work best for you and your symptoms and what risks you're going to be willing to take. So we've learned a few things. One, we've learned that timing matters. The majority of women who participated in the health initiative were postmenopausal women. These are women in their 60s and 70s or older. These are women who had very few, if any, postmenopausal symptoms, which makes sense since the majority of them were 20 years out from their last period. So this means that their bodies were no longer used to the high doses of estrogen, right? Specifically estradiol that we talked about last week. And their bodies and their brains had learned how to function in the small confines of estrone. And reintroducing estrogen back into their system is most likely what caused the harmful effects that this research found. Research has now shown time and time again that hormone replacement therapy is best used when we're in the thick of menopause, when the symptoms are at their worst. And then we stop therapy once our symptoms have reduced or diminished. So when, in fact, we found that when given to women in their 50s, hormone replacement therapy not only helps reduce our symptoms, it also has a protective effect on our cellular health and can improve overall health during this time. But if you give it to us after we've gone through menopause, it can cause damage in the exact same way. Second, the risk changes depending on if you've had your uterus removed or not. If you've had a partial hysterectomy where your ovaries remain but your uterus has been removed and you take an estrogen only therapy, then the risk of breast cancer actually reduces 22%. So it doesn't even increase your risk of cancer, it reduces it. The third thing that matters is that type matters. There's a couple different types of hormone replacement therapy, and the two most common are conjugated equine estrogen, or CEEs, which are made from the urine of pregnant horses, and these contain more than 10 different forms of estrogen, including high levels of estrone. So remember from last week, estrone is what our body mainly functions on after menopause, and it contains lower levels of estradiol, which is what our body typically, or does 100% of the time, use before menopause. And then there's the second type, which is just called estradiol. And estradiol is made from tweaked yams to become atom for atom identical to the estradiol that our ovaries produce. Because of this, we call it bioidentical, because it is literally exactly the same in makeup, function, and execution, and our bodies can't find any differences. And then the last thing that we have learned is that application matters. There's two typical ways to take hormone replacement therapy. So there's the oral route, which is just in the form of a pill, And this application seems to cause the most complications, is what our studies are finding. And while there are definitely medical indications for the oral forms of HRT, education should definitely be used. When we have an oral route, the hormone replacement therapy is then metabolized in the liver. So when using CEEs, which are not bioidentical, this may add to further complications. However, because our bodies are complicated systems, it's really hard to confirm this. And so this one is just best use your judgment and talk to your doctor. And then the second route is transdermal. So this means it comes on through your skin. And this comes in a variety of fashions, from gels to creams to sprays to patches. And these hormones are metabolized directly through the skin into the bloodstream, which may reduce some risks because it's going to bypass some of those key organs. Okay. So let's talk a little bit about breast cancer risks. There is a whole section in the book on cancers, and we're not going to have time to get to that today. If it is something that we have a lot of interest in, talking about the risks and the treatments for breast cancer when related to menopause, that is something that I can maybe think about doing another workshop or answering those in like a Q&A session, just because there is a lot and it's so very specific. And obviously I'm not an oncologist. So, but if that is something that people are wanting, we can chat about that. But let's talk about some of the risks when it comes to HRT. When we're talking about cancer risks, we also are going to have to talk about the evidence for those who have, so the risks that we're talking about right now, this is the evidence for those who have no genetic markers or a history of breast cancer. So if you have either of those, either a genetic marker, and that could be for breast cancer as well as like ovarian cancer, or you've had either one of those cancers, that greatly changes the approach we have to hormone replacement therapy and the discussion surrounding it. So we are not talking about that. We are talking about people who have no genetic risk factors or history of breast cancer. And when you don't have those risk factors, first, there is very little evidence that when you're using bioidentical estradiol and bioidentical progesterone, that the risk for breast cancer increases, which makes sense, right? If we're using hormones that look and act like ours and that our body recognizes as our own, it's not going to try and fight against it. However, the amount of time that we use hormone replacement therapy matters. Research has repeatedly shown that using HRT for longer than 5 years does increase your risk for cancer. Remember that the goal of HRT is to manage symptoms. We're not trying to stop or prevent menopause from happening. We're just trying to manage the symptoms related to them in that 5 to 7 year time frame that we can experience them. And then when taken during the proper time frame, most professional societies agree that the risk of breast cancer related to hormone replacement therapy is a rare occurrence. In fact, your risk factors are higher depending on your diet and your lifestyle than they are with taking HRT. In fact, topical vaginal estrogen has not been linked to any increased risk of breast cancer in the short or in the long term. So those are just some facts to keep in mind, especially when we're having this conversation and there can be a lot of fear or misunderstanding when it comes to hormone replacement therapy. So let's talk about the contraindications. So this is when HRT is not recommended. If you are pregnant or have unexplained or abnormal vaginal bleeding, please do not take HRT. If you have an active liver disease or high blood pressure, this has to do with the way that we metabolize HRT. Once again, not indicated. If you have known or suspected hormone sensitive cancers, we definitely don't want to increase that. So we don't recommend it. Because of this, it's recommended before starting hormone replacement therapy that everyone undergoes a cancer screening just as best practice, so that we can avoid any issues. And then if you've had or have a blood clot in the artery, vein, leg, or lungs, once again, not indicated. And last but not least, if you've ever had a heart disease, stroke, or a heart attack, we don't want you taking HRT. So these are all the contraindications. And then to better understand your personal risks, please go talk with your doctor. I'm not a doctor. I'm just someone who's done a lot of studying on this topic. Okay, so then what are the indications? We have a few. So the indications we're talking about, these are what the FDA has approved in hormone replacement therapies to treat. And so there are 3 approved indications. The first, hot flashes. Studies show that when we use hormone replacement therapy, we can reduce the number of hot flashes by 75% while also reducing their intensity. So they're incredibly effective at helping those with hot flashes. The second indication is actually osteoporosis. So if this is a concern for you or you have a family history of osteoporosis, this is a little known one, but definitely a big one. So HRT has been shown to prevent bone loss and it reduces fractures in women without osteoporosis. So this is used as a prevention method. And then last but not least, HRT is shown to greatly reduce the genital urinary symptoms. So these symptoms include vaginal dryness, burning, irritation, pain, and diminished lubrication with sexual activity, as well as urinary incontinence, overactive bladder, and recurrent UTIs. However, when it comes to our genital urinary symptoms, less than 25% of women going through menopause use HRT to fight these symptoms. And that's because of a black box warning of breast cancer. However, the reason why I talked about the Women's Health Initiative is so that you could understand where that black box warning came from. So those came from the Women's Health Initiative days. However, all the recent studies have shown that low dose vaginal estrogen has not been linked with an increased risk of cancer. And the Women's Health Initiative did not assess the use of vaginal estrogen at all. So all of that information, the knowledge that we have regarding the fact that low dose vaginal estrogen has not been linked with increased risk of cancer is from new, highly structured, well-researched data. So there should not be a fear of that. And if you're having those symptoms, this is definitely an option for you. Oh, and then just one other note. Vaginal estrogen does not increase libido or sexual interest. Systemic HRT is best for this issue, or we'll also talk about testosterone usage for those symptoms. Okay, so some additional benefits. So there are even more additional benefits to HRT, and some doctors will prescribe hormone replacement therapy simply based on these benefits alone. So the first one is sleep. This is most likely a side effect from the reduced night sweats and better regulation of the hippocampus that we see in hormone replacement therapy, and so that it improves the struggle of insomnia. So that's one of the benefits. The second benefit is there's been indications that it can help with mild depression as a symptom of perimenopause. So it is not a first-line treatment for major depressive disorder. However, if you are having depressive symptoms due to your menopause symptoms and that are most likely a response to the hormone dysregulation going on in your body, then hormone replacement therapy has been seen to help with that. And then last but not least, we have brain fog and forgetfulness. It has been seen that HRT may decrease the risk of brain fog, especially when started early. So when started during perimenopause or early menopause, It can support and even enhance some aspects of cognition, specifically memory. And so while more research is needed to learn more about the effects on brain fog and forgetfulness, especially since there hasn't been a single clinical trial on the effects of hormone therapy and dementia prevention in women with perimenopause, the research is shifting, so we may soon better understand exactly what those benefits are in regard to brain fog, forgetfulness, and dementia. Okay. Now, I did want to mention that this research is ever ongoing. So there is even a whole new generation of hormone replacement therapies that are being studied, which is good news because it means we're getting better and we're eliminating those risks even more. And so for years, we have been using selective estrogen receptor modulators, or SERMs, when fighting cancers, specifically breast cancer. So SERMs have the ability to block estrogen receptors in the body, such as in breast tissue, which stops the estrogen from binding to cancer cells and growing, while mimicking the effects of estrogen in other part of the body, like in our bones, where the estrogen has a beneficial effect. So basically what SERMs do is they basically pick and choose what receptors they're going to either block or enhance, which is amazing when we're working with cancer, right? But it's really important when we're looking at menopause because it indicates that we could use SERMs to target specifically perimenopausal and menopausal symptoms while letting go of some of the associated risks like cancer. And so this is currently actually undergoing research and clinical applications, specifically by Dr. Mosconi. And they're using what is called phytoSERMs. So phyto means plants, right? So it's a SERM derived from a plant that bypasses our reproductive organs, thus minimizing breast cancer, uterine, and ovarian cancer, and instead delivers all of the benefits of estrogen straight to the brain. And so the results are actually very, very promising. And according to her book, that research is due to be released this year. So hopefully we're making really good progress on that front. And then just a friendly reminder, there is no one size fits all when it comes to hormone replacement therapy. And I know that that can be really frustrating, especially if you're joining in on this workshop because you just feel out a loss on how to treat your symptoms. But I want to give you the most information possible out there, but also be real with you and knowing that you're going to have to talk to your doctors. You're going to have to try and maybe do some lab work to figure out what is going to be the best fit for you when it comes to hormone replacement therapies. And if that was not confusing enough, we have even more options beyond just estrogen replacement therapies. And so let's chat about some of those other ones. So we have two other hormonal replacement therapies, or not replacement therapies, just hormonal therapies. And the first one is testosterone. So our body needs testosterone to make estrogen. And so because of this, we typically produce 3 times more testosterone as estrogen before menopause. But because of this, testosterone can decline after menopause. And I say can because testosterone is produced, yes, in the ovaries, but it's also produced in fatty tissue and the adrenal glands. So some people may see a drop and some people may not. Testosterone also fluctuates over time, and the amount that we need differs from person to person, which makes it a very complicated hormone in and of itself. However, the result of low testosterone can result in libido issues, as well as symptoms of anxiety, irritability, depression, fatigue, memory changes, and insomnia. However, when looking at those symptoms tend to be overlooked when being evaluated for treatment, just simply from the way our medical industry is made when it comes to testosterone. It's just usually not looked at for women. So currently, the only clinical indications for testosterone therapy is if you are postmenopausal, you're taking estrogen therapy, and you have a decreased sex drive or libido with no known cause. Or if you have reduced sex drive, depression, and fatigue after surgically induced menopause, and estrogen therapy has not helped. So those are currently the only indicated clinical, clinical indications for testosterone. But obviously there could probably be more. So talk to your doctor about that. If you choose to try testosterone, know that you typically receive the hormone transdermally through creams, gel, or patches. And second, you don't necessarily need a lab test to determine if it's a good choice for you, because testosterone levels in the blood does not always indicate symptoms. So if you're having symptoms and this is something you talk to your doctor about, you don't even necessarily need a lab test to determine if you want to try it. However, if you decide to try testosterone, then it may be helpful, especially that first year, to periodically check your lab levels so you can make sure that your dosage isn't too high, since we do fluctuate throughout, not even just our cycle, but just throughout the year. And then the other hormonal therapy that you can consider is hormonal birth control. You may have thought you were done with birth control, but it has been seen as a way to manage menopause symptoms. However, it's important to weigh all the risks, as hormonal birth control is not recommended with those with a history of clots, certain types of cancer, and other health conditions. They can also increase the menopause symptoms of weight gain, breast tenderness, nausea, mood swing, and decreased libido. So it's important to balance, right, the risks and the benefits. One of the benefits is if you are perimenopausal, meaning you are still having irregular periods, or you're still having regular periods but experiencing menopause symptoms, then hormonal birth control is a very effective way to prevent pregnancy, because you can still get pregnant anytime you're having a period and still ovulating. But it can also help relieve some of those symptoms. Hormonal birth control can also safely be taken along with hormone placement therapy. And so hormonal birth control, when it comes to menopause, has been seen to help with cycle regulation and reducing irregular bleeding, reducing the number and severity of hot flashes, increasing bone density, and reducing endometrial and ovarian cancers. So there are some indications that hormonal birth control could definitely be helpful in those situations. Okay, I also want to talk about antidepressants. Antidepressants tend to get a really bad reputation as we enter the menopause phase of life. And this is because when we bring up our concerns and our symptoms to providers, sometimes we can just get brushed off as women, and we can be diagnosed with anxiety and depression and thrown on some antidepressants as a solution, when truly the symptoms that we're having are menopausal. And because of that, they may need to be coupled with a couple different lines of treatment. And so it's really important that when we're feeling that depression, that we're having our providers doing their due diligence to make sure that this is truly depression or anxiety, and not hormone related. But when antidepressants are used correctly, they have the ability to act double duty and offer relief of depression and anxiety, as well as reducing menopausal symptoms. So there are two main types of antidepressants that have been studied for menopause relief, and those are SSRIs and SNRIs, which target the serotonin and norepinephrine transmitters in our brain. Both have been seen to effectively reduce the menopause symptoms. And I wanted to make sure that you could see on the screen which ones of those have been studied. So now don't hate on me for my pronunciation, because this was my biggest concern with this workshop, was pronouncing all of these medications. But paroxetine is the FDA approved treatment for moderate to severe hot flashes. And then a low dose has also seen to improve sleep without a negative effect on weight or libido. And then Celexa, Lexapro, Effexor, and Prestique have all been seen to have a moderate effect on hot flash reductions. Depending on the medication you're on, it seems that there's a 50% to 62% efficacy in reduction and intensity. So if hormone replacement therapy stresses you, but you also have major depression or anxiety, and maybe you're on these medications, this is an alternative route to that hormone replacement therapy that can help with those hot flashes. I do want to note that Prozac and Zoloft, which are very common antidepressants, do not work well for menopause symptoms. So those are not indicated as helpful. Okay, so now there's 5 different non-hormonal therapies that we're going to go over. These are ones that you may have heard of, but maybe not in connection with menopause. But once again, these are non-hormonal medications that have been seen to be effective when treating menopause symptoms. So the first one is that one. I don't even know how to pronounce that. Fezolinetant. It's designed for the treatment of moderate to severe hot flashes. So this is actually a new drug that has hit the market. It's FDA approved, and it's approved specifically for the treatment of hot flashes. The way that it works is it blocks a specific protein that binds to a specific receptor in your hypothalamus that regulates body temperature. So basically, it's just alleviating the severity and frequency of hot flashes by not letting that protein bind. A high dose of it has seen a 48% reduction in the number of hot flashes as well as the severity, and a low dose is seeing a 36% reduction. So it doesn't get you quite as close to that 75% reduction that we see in hormone replacement therapy, but it can definitely help. The side effects are GI issues and possible liver damage. So it has seen some enzymes increase that can indicate liver damage, but no liver damage was seen during the duration of the clinical trials. Okay, the next one is gabapentin. This is FDA approved for epilepsy, but also has seen to improve the frequency and severity of hot flashes. It naturally promotes sleepiness, so it can be a really good match for women who are struggling from menopause-related sleep issues, because it's naturally going to make you sleepy. It can be taken as a single nighttime dose, or it also can be taken during the day, but just remember that it will make you sleepy. The side effects are dizziness, unsteadiness, drowsiness, but typically symptoms improve after 2 weeks, but there are withdrawal symptoms for when we stop. Okay, 3 more. Pregabalin, which is very closely related to the last one that we talked about, is commonly used for seizures, pain, and fibromyalgia. You may have seen the commercials for Lyrica. That's what this is. But it has also been seen to reduce hot flashes as well as reduce menopause-induced anxiety. Another important note for this one is that it can be taken with tamoxifen and aromatase inhibitors, which are commonly used for breast cancer treatment. So it can be used in pairing with cancer. The side effects are the same as the last one. So it's going to be dizziness, unsteadiness, drowsiness. Typically those side effects improve after 2 weeks, but then there are withdrawal symptoms. And then there's clonidine, which helps lower blood pressure and prevent migraines. But it may also reduce hot flashes. However, this is seen less effective than antidepressants or gabapentin. But it is also a possibility. However, it's often recommended as a last resort. The side effects are low blood pressure, headaches, dizziness, and sedative effects. And then the last one is oxybutynin, which is used to treat overactive bladder and urinary incontinence, which can be a very common menopause symptom that we just push off, but it's also been seen to help with hot flashes. It can also be taken with tamoxifen and aromatase inhibitors. So if you're struggling with cancer, this is an option, one that can help with that lowered immune system, which can then create an increase of UTIs, but it can also help with those hot flashes. And the only side effects are dry mouth. Okay, those were all the hormonal and non-hormonal birth controls. Thank you, Carrie. I worked really hard in practice on that pronunciation, so I appreciate that. What questions do you have? Because I know I went through things fast. There's been a lot of questions when it comes to hormone replacement therapy, so I wanted to ensure I gave you time to ask any specific questions that you have.
Sorry if I can unmute myself here. So my doctor prescribed, I think it's estradiol,
Yep.
and I think I heard you say that that particular method is safer.
Mm-hmm.
Okay.
Yes. So I can go back. Let me go back to that slide. Okay. So estradiol, that's the second one under type. Once again, that one is tweaked from yams. So estradiol is technically, it is bioidentical because it's no different from the estrogen that we produce in our ovaries. And so it tends to have a much lower risk for pretty much everything on the board because our body recognizes it as the same as what we already have. Obviously, the risks for that would be if you have a genetic history or a genetic predisposition to certain types of cancers. It's not going to matter what type of estrogen is in your body, that could be a risk factor. So does that answer your question, Deborah?
It does. Thank you.
Perfect. Okay, let me just read the chat. If you have a problem with clotting, what is your best option? The vaginal one. Yeah, so this is one that I would definitely talk to your doctor with. The vaginal one, there has not been any, there's been no risk seen for cancer, but I feel fairly confident that that goes with clotting as well, but I would chat with your doctor on that one for sure. Next week, will you go over non-medication options? Yes. So next week, we're going to be talking specifically about our food and some of those more homeopathic remedies that maybe you've heard of. So we'll go through a big list of those and then the way that we can eat and the specific types of exercise that can help with menopause symptoms. So those will all be talked about next week. I use estradiol patches twice a week and progesterone at bedtime. It's helped tremendously with hot flashes and night sweats. Good. I'm so glad about that. Okay. Any other questions?
I will just echo that last sentiment. I use estrogen patches that change out twice weekly and then a micro progesterone capsule at night, and my sleep and night sweats and vaginal dryness and nighttime awake anxiety have all gotten better. So
Good. I'm glad to hear that. Yes, we've made really good strides with doctors being more willing to prescribe HRT. And so that's been a really important push for women because after that 2002 fiasco, it was definitely not recommended. And a lot of women didn't get the help that they need when it comes to hormone replacement therapy. Okay. Please continue to throw your questions in the chat. I did want to see, so I posted, sorry, now my computer's being slower. Okay, so I did want to pose a question. I have this QR code up on the screen where I had it up on the screen last week as well. And a lot of you went in and asked some questions, and there were some really, really good questions in there that I'm just not going to get the time to be able to answer and go through. I just want to see where the interest would be if I held a Q&A workshop all on menopause, where you could even scan this code again, ask your questions, and anything that's not been covered over the last 3 weeks, I can spend some time answering that. It would be on Monday, April 15th. I would, of course, record it, so if you can't make it, thank you, 14th. It's whatever that Monday is. So Monday, April 14th, from 12 to 1. I'm just going to throw that date in the chat. If you're interested, if you would just like that, and if there's enough interest, I will throw that onto our calendar so that I can make sure that you guys have the opportunity to have your questions answered. If there's not enough people, then that's okay, and I can answer those questions individually as they come. Jacine says, I've been on HRT for many, many years and need to talk to my doctor at my next annual exam. So great, I love that. So yes, like I said, next week we're going to be talking about lifestyle and integrative health, and there will be so much more coming. Deborah said, my testosterone levels were extremely high, so she prescribed that one to lower them. Are there any homeopathic remedies that can help reduce testosterone? I will have to research that one, Deborah, because she covers certain plants and foods that we can eat that can help naturally increase our estrogen, but I don't think she talks a lot. Well, I know she doesn't talk about testosterone, so I can look at that one. But Olivia threw in the chat, spearmint tea can help. So there's that. And yes, that's the crazy thing too about testosterone is it can go really high or really low. And so that's where when it comes to taking testosterone therapies, it can just be tricky because our bodies are just built a little bit differently. What about increasing testosterone naturally? I will research it. I will make sure that I have at least a little bit of information on ways that we can talk about testosterone naturally and through our foods next week. That's for sure something I can cover. Great. Okay, any other questions? Okay, my biggest issue is the hair growth from the hormone therapy. I typically put it on my, but I wondered how it would affect my arms if I put it there instead. Any suggestions? Yeah, so I can look into it. I know that in her book, she talks about that for the most part, any creams can be applied anywhere. But since one of the side effects are hair growth, it's really just where you want to deal with that side effect personally. So at least with your legs, right? Theoretically, you can shave off your extra unwanted hair. But no, unfortunately, it can. That's just one of the side effects of the cream. It looks like Jacine did the cream on her tricep. So you can always just try it in a different location and see what the result is and then change it up again for that. But there's no like right or wrong place when it comes to the cream. Yes, of course. Any other questions? Is there a specific type of doctor for the medication? So typically when it comes to menopause, we get bundled in with the OBGYN. So you can talk to your OBGYN. Some primary care physicians will also work with you, especially if you're a woman in your late 40s or 50s and having all the symptoms. That's not something any kind of specialist needs to diagnose you with. And so they'll just use your list of symptoms as oh yeah, you're in perimenopause or you're in menopause, and then they can help from there give you your medications. So it's really up to your preference and kind of age range and what your symptoms are, whether or not your OBGYN or your primary care physician would be best there. Did you say if you had a partial hysterectomy and are using HRT, you can lower the risk of cancer? Yes. So I want to give you the exact stats. I want to say it was 22%, but I'm pretty sure. Let's see if I wrote it down. I didn't write it. Let's see what my notes have. Yes. So a partial hysterectomy can reduce the risk by 22%. So, yes. Yes. So Andrea put on there, the Menopause Society has a lookup tool to find healthcare providers that specialize in menopause. The website is menopause.org. I highly recommend it. She talks a lot about how in the book that there's just very little training when it comes to menopause, and really very little research, which is what makes this book and a couple of the other ones that have come out so revolutionary, is because the research is so little, and when there is research, it's usually lumped into a whole bunch of other studies, and so it's hard to sift through for the layperson like you and I who just don't have the time to read study after study to understand what we should be doing for our bodies. And so yes, using menopause.org is really important to make sure that we're trying to find doctors that are trained in menopause, but if not, there's a lot of books, the Menopause Brain being one, the Menopause Manifesto is another, that can help at least point us in the right direction so that we know what questions to ask and what medications are out there when we're talking to our OBs or our primary care physicians. There are OBs that specialize in menopause or postmenopause and don't deliver babies. Yes, this is true. And we're currently working with St. Mark's to have one of those doctors out and also do a training for everyone. So be on the lookout for that one. Okay, let's see. I'm experiencing itchiness on my face and noticeable hair loss, including thinning eyebrows. Do you have any suggestions? I don't. That was not covered in the book. It was mostly just covered as, yes, those are common symptoms, the skin and the hair loss. I can do some research for you, Vanna, and see if there's anything else that I can find for that one. So I will take a look. Aaron says, no money in it, no R&D into menopause care because nobody stands to make a fortune off of it. Yes, unfortunately, that has typically been the rhetoric, which is why Dr. Mosconi's work has been so amazing, because she has opened up an entire initiative and work group out of New York, as well as the Cleveland Institute, that has helped really increase our studies and our funding behind menopause. And my sister actually just went to a medical conference the other day where they spent a whole session talking about menopause and the money that could be made off of its research. So I think it is coming into the R&D soon. Another recommendation is Hot and Bothered. And yes, I'm sorry, Jessica. So Jessica says, for reference, my PCP was 0% effective in helping with addressing my concerns about perimenopause. Instead, She insisted I was too young, regardless of all of my symptoms, and I found a practitioner and an OBGYN and cried because I finally found a care team that listened to me and took me seriously. It is tough out there for us. Yes, it is. So that is definitely a struggle for sure. And once again, we as women tend to be glossed over, patted on our heads and go, it's not that big of a deal, or you're just a woman. So make sure that you find a care team that will listen to you. Kristen says, just to clarify, as I understand, a total hysterectomy removes the uterus and cervix. A partial hysterectomy leaves the cervix and lower uterus. Yes, there's several different times. So partial hysterectomy that Deborah was mentioning was when they leave the ovaries, where they're just removing the uterus and the cervix, or just the uterus, or the uterus, cervix, and fallopian tubes. They all have different names. A total hysterectomy is when everything is removed. And then Shelly, I found that you have to be the one to request it and bring up the info at doctor's visits. They don't bring it up to you, even if you are actively going through it. You need to be pushy and proactive for yourself. Yes, and we kind of chatted about that last week. If you're having any symptoms, please, please, please speak up for yourself. Don't let your doctor push them aside or tell you that you're too young or any of that. When our hormones start to get dysregulated, we're going to have symptoms. As people who have the XX, body, our brains and our systems run off of estradiol. And so when those start fluctuating, we start having symptoms. So yes, speak up for yourself. Okay, I am going to let you guys go. Once again, if you have any questions, please feel free to ask them, scan this QR code, and I will make sure that I try and answer them the best that I can, either next week or we'll do that Q&A session. It looked like there was enough people interested in that. So thank you guys, and thank you for being engaged, and I will hopefully see you guys next week. Have a good one.